I'm curious, for those of y'all in the room, if we could also do a show of hands of how many folks in here receive their insurance through their employer? Majority. How many in this room receive their insurance through the individual market or an Obamacare exchange? Good portion. And then how many in here may receive some help through a Medicaid program? All right. I think dividing out the insurance marketplaces that way is probably a good starting point to talk through where the Republicans in Congress are trying to go. First and foremost, my last job on the Hill, the absolute last day that I was in the office, we were working on what would we do if we had the ability to significantly alter the ACA. What would be the primary changes that we can do? And I think talking about ACA as only repeal misses the point that the Republican leadership has always been for repeal and replace. What does that mean? What does repeal and replace mean? And I think what you're seeing right now and reading in the press is the dynamic of different viewpoints about how far one goes with the current marketplace. So what might be helpful for you all, since you all are going to be going up to the Hill and meeting with a lot of folks, is giving you a little bit of a background about what the Hill's thinking about right now as they take on a very large task of repeal and replace. I disagree with Wendell. I think they will get something through. The question is how much policy is in that package. So think about it in these terms. Speaker Ryan talks about it as 3 buckets. You have the reconciliation measure, and the reason that they're looking for that measure is that it only requires 51 votes in the Senate, not the 60-vote margin. It's the same measure that was used originally to pass the ACA, most of its pieces. But notably, when the ACA was passed in Congress, it was not 1 bill. It was 2. And there have been several actions that then had to be taken by the Obama administration. So bucket 1 is what can move through parliamentary procedure through the Senate with 51 votes. We already know that the House and the Senate can clear a bill with 51 votes. They did it last Congress. The distinction is you actually have someone in the White House that will sign it. So I disagree with Wendell. There is a base bill that passed last Congress that could be passed by both the House and the Senate and signed by President Trump. The conversation that's going on right now, and it's an important conversation, is what additional replace measures can move in that vehicle so that it's not just repealing provisions of the ACA, but you're actually rebuilding the law. And that's where you're seeing the distinctions in the press. So yes, you can clear a bill through the House and the Senate and to President Trump, but what provisions can you actually pass with at least 51 votes in the Senate, or more importantly, more than that? So you've got the 51 vote threshold, vote 1. The second action, and you've already seen these actions in place, so maybe I should have put that first, is executive action. What can this White House and Secretary Tom Price do to improve policies that are largely driven by the administration in the ACA? We've already seen actions that Secretary Price did to stabilize the insurance marketplace. Republicans did not destabilize the individual insurance marketplace. The marketplace was destabilized prior to the November election. Even if Secretary Clinton had been elected president, there would have required actions to stabilize that individual marketplace. Every financial analyst will tell you that. The insurers will tell you that. It is a problem shared by both parties. So the questions are, why did it take so long to try to take some of those actions? Why did the Obama administration not take them? Why is Secretary Price taking them now? And what more authority does Secretary Price need to stabilize the marketplace? Or is this a congressional function to stabilize the marketplace? And that conversation's going on right now. And some of the issues have to deal with money. Some of the issues have to do with insurance regulations. And some of the other issues just have to deal with the complex task, for those of you all who may live in areas that only have one plan, of how do you get more competition into certain areas so that people are not only left with one insurance option. Because I know the folks in this room appreciate insurance is only as good as the coverage it provides. So just having assurance alone isn't necessarily the only step in having quality healthcare coverage in the U.S. And then so bucket 1, reconciliation. Bucket 2, executive action. Bucket 3, what can actually get bipartisan support through the regular legislative process. So if you were to pass a bill in the House, how could you get 60 votes in the Senate? And many of the provisions that people would like to put in the reconciliation bill, because of parliamentary rules, can't go in the reconciliation bill. Here's a good one. The Medicare Independent Payment Advisory Board. It has not started. It's the board that's often highlighted that people, I've never referred to it as a death panel, but often its actions and its ability to ration the type of care under Medicare, many people have translated that to being a problem. That board, you cannot eliminate that board through reconciliation. You can't address some of the insurance market reforms through reconciliation. What other policies could we possibly come together on a bipartisan basis to pass through that third bucket? So that's how the Hill's thinking about it right now, and I would not be surprised at all when you meet with staff members and members of Congress on the Republican side of the aisle if they talk about it in those 3 sort of buckets and terms. It's fluid right now. The biggest conversations in Replace are indeed about what to do with the individual marketplace. How do you stabilize it so that insurers will participate? It's not minor when major insurers say that they will not participate in the 2018 exchanges. The second thing is there's a different conversation going on about how you help people pay for to participate in the individual insurance marketplace if you can't afford it. And Wendell already highlighted that one of the concepts is this advanced refundable tax credit. How you structure that tax credit, how you build it in is very important, and I would argue that the overarching conversation with that tax credit is your subsidy only works if it helps you pay for insurance that you can afford. But if insurance costs keep going up, what's going to happen with that subsidy? And so the conversation is very much a budgetary issue right now on the Hill, which is not ideal for patients in this room because who wants to be considered a budgetary issue? But it is an issue right now of trying to design that tax credit in a way where you try to drive down healthcare costs, make health insurance more affordable for folks so that the subsidy is really meaningful. So that's sort of bucket 1 of the large Replace ideas. The second one is the issue for those of y'all who right now are on Medicaid. Depending on what your state is, your state may have expanded or it may not. Some states have more functioning Medicaid programs than others. Many governors will argue that the Medicaid budget is cutting into the rest of their state budget and that reforms need to be made. So because you have 50 distinct Medicaid programs in this country, there is a very lively conversation going on right now, even amongst the Republican governors from those expansion and non-expansion states, about what are the flexibility and policy changes that they need to reform some of those programs, and how do you fairly balance out states that chose not to expand, states that chose to expand, and make sure that people who need access to coverage, especially those who are most vulnerable, have access to coverage. The distorting thing about the ACA is that those in expansion states are actually paid more for the patients in that space instead of those who are most poor and most vulnerable in the state. And that's a mixed match of federal funds. And those are the issues that they're really trying to work through. And on that, I just want to wrap up with, I think there's so much frustration about how far apart Republicans and Democrats are on the overarching design of healthcare reform in this country that we miss the pieces where we actually agree. And I would say that we do agree on making sure that everyone with a pre-existing condition has access to healthcare. I've yet to hear any of the Republican leaders start a conversation on healthcare reform that doesn't address that issue. There are different ways to get at it, but there's not a single Republican leader that I've worked with on the Hill who has pen in hand drafting the legislation that doesn't believe that that is a primary focus of any bill. And so as far as I understand it right now, you will have protections for pre-existing conditions. There is no interest in bringing back lifetime limits. And many of the provisions, like making sure that folks to age 26 can stay on other forms of insurance, crossed in Republican and Democrat policy proposals. So I do think, although there is a lot of angst and rightly so, about where are we going next, because there are a lot of things up in the air with health reform. I think, having a little bit of calm and recognizing that there's different paths forward and there's lots of options here, and not treating it as one thing, because our healthcare system is not one bill, it's not one action, it's constantly evolving. And how do we make sure that the policy issues we value most of innovation, making sure people have access to care, and lowering costs so that it's affordable, at least those are all in my buckets of things that I care about. Getting access to the people you need, that remains at the forefront. And I spoke too long, but I hope I answered many of your questions, and we'll get to questions right after that.